We have a quorum, so why don't we get started and people will come in. So we're very very lucky today to have Dr. Joshua Safer here. So Dr. Safer is Executive Director of the Center of Transgender Medicine and Surgery here at Mount Sinai and Senior Faculty at the Icahn School of Medicine. Previously, he was Director of Transgender Medicine and Surgery at Boston Medical Center at BU. He received his medical degree from the University of Wisconsin and completed internal medicine residency at Mount Sinai Beth Israel downtown before endocrinology fellowship at Beth Israel Deaconess in Boston. On the national scene, Dr. Safer is president of the U.S. Professional Association for Transgender Health and is a steering committee co-chair of the International Transgender Research Consortium, Transnet. He also serves on the Global Education Initiative Committee for the World Professional Association for Transgender Health and on the Standards of Care Revision Committee for the same, and as scientific co-chair for the World Professional Association's international meeting. He's co-author of the Endocrine Society Guidelines for Medicine Care Transgender Persons in fall 2017, and we're very lucky to have him here this morning to speak with us. Thank you.
Thank you for the introduction, and I think it was set to be just long enough for a few more people to get in. So I guess let me just talk. I don't know. Do I need the microphone for here for other people here all over? Okay. So because the room isn't that big. So what I'm going to do is I kind of have three broad themes to the talk here. Number one is just going through. Many people may know, but just go through some of the data underlying how we think about gender identity. Talking a little bit about why we think about this so differently. Why this has suddenly become mainstream medicine. And the second is, and I'll touch on kind of healthcare delivery a little bit as we do that, and then I'll talk about the hormone strategy, the medicine piece, and what data we have or we don't have. And the subhead here is care strategy and knowledge gaps. Mostly we have knowledge gaps, but anyway, I'll touch on that too. Opportunities for research, which we have, and I think that's another key interest for the program here at Sinai, and then we can go off and talk about whatever else you want to if I talk fast enough that we actually get through all of this. So I'm supposed to have this conflict of interest disclosure. I served on an advisory panel once for endopharmaceuticals earlier this year, and this being endocrinology, of course, FDA indications don't correlate with use. I think I already said this already. Why we see change to our approach care is kind of the big thing, and then what is our current hormone strategy? What are we really trying to achieve with the patients for the most part? All right, so just a little bit of a lay of the land kind of circumstance. Actually, I just realized I even may get a little in-between slide that isn't done in this version of the talk, I don't think, but we'll see if it shows up. But basically, people have thought of transgender individuals as having a mental health disorder, and historically they have sought out care from mental health providers who then have this kind of ad hoc treatment regimen, which makes no sense, following mental health paradigms, where they, what to the rest of us in conventional medicine appear to be abetting the mental health concern instead of taking care of it head on. And that's been the tension, I think, and part of the reason why this has been more of a fringe topic in decades past. The result, though, is that from a healthcare delivery perspective, what you have out there are mental health providers who meet these individuals, really observe that these people don't otherwise have what would appear to be a mental health condition, seek hormones for those individuals in an ad hoc fashion, and seek surgeries the same. And the result is the systems that have developed are these workaround kinds of systems where maybe somebody helps out or a primary care person has a little niche in some remote location. What happens also in some big cities is just a standard thing for transgender women specifically. And notice that I didn't just open my talk up with a bunch of terms, because there are only like 4 terms really, and so we'll kind of use them appropriately, and I trust that you'll follow, and if you want, you'll ask. So transgender women, male to female. A standard thing is a big economic hit when these individuals start to reveal or start to act or do medical interventions that change some of their appearance, and that's just across all socioeconomic levels. So up in Boston, I had patients. One patient is a Fortune 500 exec, living off of her 401k because it took them about a year to find her transition icky and to get rid of her essentially. And you can just work your way right down the line in terms of people's affluence. And so you have middle class people who are suddenly on assistance, and you have people who are in more extreme circumstances that get to even more extreme circumstances. And there's going to be a subset of those individuals who end up in the sex trade, who end up contracting HIV, and then that ends up looping back into this healthcare delivery reality, which is lack of access to providers who actually have prescribing privileges around the country. And in big cities, some of the people who are in the worst circumstance who actually got HIV show up in our funded HIV clinics, because after a lot of the 1980s, we actually funded our HIV clinics in a not so terrible way. And there they find an ID doc often, or a general medicine person who has prescribing privileges, who gives them their hormones, and then all of a sudden you have this backdoor avenue where even trans people who don't have HIV then are showing up at the HIV clinic. And that's actually what we're still doing at Sinai to a degree, or what we've inherited. The old HIV clinic that turned into the big LGBT multi-center site across all of Sinai, the one down in Chelsea where our main operation is an old remnant of St. Vincent's in the day. And so that's actually how that comes to be, and that's typical for a lot of cities. When I was in Chicago, just not too distant past, they didn't really even have this in endocrine or primary care. They had an ID doc on the south side of Chicago, out of the University of Chicago, running trans care out of an ID clinic, and so there's that disconnect as well. All right, so I said I would go through a little evidence, because my logic pattern is to be evidence-based in my thought process, which, by the way, also means that if we gain new data and think about things otherwise, then we will shift our framework a little bit. This is another observation, is I'm going to try not to be political at all, although there is obvious advocacy that comes forward when you look at what the data seems to show for the moment. So we had thought that the potential factors determining gender identity were environment, and what I mean by that is what your parents told you, and you've been kind of going with it, versus it just being a societal construct, this kind of wishy-washy thing, which has been popular over the decades. And then potentially the one that I think I would have believed myself, in fact I'm pretty certain that's what I believed, even if I found it being true and honest, is passive response to anatomy, which is you basically look down between your legs, you saw what you had, you've been living this way ever since. But apparently that's not true, and to the surprise of a lot of us, there are data for this, there being some substantial biological underpinning, and that's, in my view, certainly for my own purposes, that has shifted my whole thought process in terms of how we approach this, and I think that's had huge influence in mainstream medicine as well. So I want to walk through just what that really is right now, and that's its own topic for further investigation, frankly. And I lined it up in the order of how convincing I think the data are, so in categories. So first is historical attempts to manipulate gender identity. The classic circumstance for that would be intersex individuals, or people with various circumstances. We would call them, maybe they have ambiguous genitalia at birth, and it has been the case for many decades that you can do surgery to create female genitalia, that is a vagina. The techniques for making that look better to mostly a male surgeon, actually, if you think about who's actually making these decisions. But in terms of function for penetrative sexual intercourse, which is kind of the lens to which they were viewing this whole thing, those techniques are superior than the techniques to make male genitalia. And that's actually true currently. And the tail end of the talk here, we'll talk about surgical options for transgender individuals, and the result of those different technique realities does influence surgeries for transgender people currently. But anyway, this has been the case for a number of decades, and the result, therefore, is that if gender identity could be manipulated or was external, then when you have people with various circumstances, why not just go with the surgery that is where the surgery that's going to work best, and then you'll influence the gender identity. And the literature still says this. People have boilerplate that they're still sticking into chapters where they say things like, and I'm talking about like WPATH and transgender-friendly organizations where they still say, well, gender identity evolves and it gets defined by the age of 5, and it gets worked out in the first 18 months of life, and prominent people still write their reviews, and they open up with that stuff, and they reference all the classic references that go back decades along those lines. But that's exactly the paradigm that got us to the wrong place with the intersex individuals. So what I have up here is just a representation of the one good paper on the subject. Frankly, there are a bunch of little case series things, but the only real paper on the subject is the Johns Hopkins urology group, where they were basically doing this surgery with one particular maldevelopment syndrome where there was a lot of surgery for the GI-GU tracts, and therefore basically all individuals were getting female genitalia and raised as girls. So they looked specifically at the 16 of their kids over the years. They were a center. It's not that common a circumstance, but they're a center. And they looked at the 16 XY individuals to whom they did this. And the reason they even got the idea was that 4 kids, so it's a fairly involved surgery, these kids keep coming back, even if from across the country, they keep coming back to Johns Hopkins, let's say every so often, every year or so, for additional surgeries, for follow-up, et cetera. And so 4 of these 16 kids, XY individuals, where if you just take a step aside here a second and think about it, gender identity, the way we think of it is right now, when you survey people, maybe 0.5% of people say they're transgender, which means that 99.5% are not. Which means if just statistically you've got 16 people and they're XY, probably all 16 of them have male gender identity, just so that we're clear on this. Anyway, 4 of those kids around junior high said, oh, and remember, they followed their, one other thing of which to be clear, and those of us who are older know this, I remember doing this in Wisconsin, actually, we were in med school. We walk around, we were very serious and thoughtful, those sort of things, and we told the parents what gender identity, what the gender of rearing ought to be, and then you do your surgery quickly before 18 months because gender identity forms early, and that way you've dealt with the issue of them looking down between the legs problem. And then when they hit junior high, you start to give them the appropriate hormones, and you raise them in a sex stereotypical way, just to really drive home the point to them. And then you don't tell them their medical history until they're age 18 so that they won't be confused. So it's a really sophisticated brainwashing framework if it's going to work. Anyway, 4 of these kids, junior high, say they're boys, and that's what got the study going. And the bottom line of the whole thing is that by the time they started investigating, and a few of these parents, were dysfunctional and accidentally talk at the dinner table and told their kids their medical history before they were 18 and other things like that. Every single kid who knew his medical history was identifying as a boy by the time they wrote their paper. There were 5 girls unaware of their medical history as of the time the paper came out, and that's about it as far as the data on that particular subject, and that kind of group fell apart. All right, in terms of broad categories, the second category, really I'm coming down to one paper, which is a synthesis of the case reports of twin studies. Because people say, oh, if it's biological, then what's the situation with twins, right? So nothing about separated at birth or that kind of thing. Just twins growing up together in the same family. And the statistics are really this. If you have fraternal twins, if you have a transgender individual as a fraternal twin, the twin is not transgender in all the cases that have been reported so far. If you have a transgender person who has an identical twin, then like 40% of them, the identical twin is also trans. And just in terms of this kind of concordance rate, just to put it in perspective, that's not too far off from type 1 diabetes with a very, very tight and obvious genetic linkage. So that's useful to say again, especially when you talk to a lay audience where they're like, well, identical twins are not identical, and right, that's true. But there's this very tight linkage where the association fits closer with closer biology. The other thing, which I think is kind of cool and probably only in terms of percentages actually, which is the uteroandrogen exposure data. So there are 2 kind of streams there. So on the one hand, virilizing congenital adrenal hyperplasia, if you survey those who are women, then about 5% will report male gender identity. So there are a whole bunch of support organizations out there for people who have virilizing congenital adrenal hyperplasia, and they're all panicked that we'll be confused on the point. And it's important to emphasize, especially again when you talk to lay groups or whatever, that 95% have female gender identity. So this is not what aren't going to predict male gender identity in a kid with virilizing in an XX individual with virilizing congenital adrenal hyperplasia. But on the other hand, 5% seems to be a lot higher percentage than the 0.5% of male gender identity we see in the general population. So something is happening to some susceptible individuals at least. The other piece, which is maybe even more interesting, is the other side of it, which is complete androgen resistance syndrome. So there's kind of a range of them, varying degrees of androgen insensitivities based on the androgen receptor. And the complete syndrome, so the androgen receptor does not recognize testosterone at all. Those individuals, you may recall, their external appearance is entirely female. They don't have any of the other genes that came with XY because they weren't XY, the Müllerian inhibiting factor and such. And so they internally, they never did develop the female reproductive organs. So the top third of the vagina, the uterus, the ovaries, etc., are not there. Those kids become identified mid-high school, right, when they don't menstruate, and then they have the shock that they're not going to be able to have babies and stuff, and that's their circumstance typically. Point though is they all have female gender identity. So in the abs, so these are XY individuals with a complete resistance to androgen. There's no ambiguity among them reported so far. Very, very clear female gender identity. It almost suggests that you need a little testosterone maybe to have a male gender identity. The last one, and the weakest, but the prettiest pictures, the ones people sometimes put up, are the brain anatomy associations with gender identity. I think that's something that where we could study things a little bit in a more sophisticated way. The classic one is still a bunch of cadaver slices that are stained from the 1990s because those are the most granular data. That attempts to replicate what I'm about to show you with MRI and PET. Those modalities are too superficial, is my view on that. But if we could be a little more functional, maybe we find something. So let me just show you what they did. They were looking at a region of the hypothalamus where they had associated in mice and rats the manipulation with this region with what they perceived to be homosexual behavior. And they were looking for the quote-unquote gay gene at the time. That was the logic pattern of the research. And I love this research because everybody, if you're just honest with your research, even when you make stupid mistakes, you might learn something else, so long as you really report out your data and don't get too hung up on your theory. So what they essentially what they decided is, the problem, if you think about it, the mice and the rats, is they didn't know if these mice and rats were gay or trans, but nobody could speak rat or mouse, it turned out, and so nobody could really clarify that point. But as it relates to the humans, they thought, okay, well, let's slice that region of humans. And this is the crudest, stupidest study, actually. They took slices of human brain. Obviously, the volunteers had died before they were sliced. And they stained the male of the guys, and they got this intense staining pattern. And it was with this is totally random antibody. Like, they don't even know what they're doing. Okay, this neurology group. And then they stained the women, and they got no staining. So then they go look at the guy specifically is reported to be straight, and they go find some dead guy who's reported to be gay, and they stain, and lo and behold, it stains exactly the same, and so they have negative data. But back then, they conflated, like a lot of people still do, gender identity with sexual orientation. And so they thought that transgender women were gay men who were, I don't know, or gay, or I'm not really sure kind of how they understood that. But the bottom line is they thought it that way. And so the result is that they actually stained some transgender women, and lo and behold, they stain like the women who are not transgender. And then they did a whole bunch of controls, controlling for women who got the transgender women who had their hormones, who never got treated, and also among the non-trans folks, individuals who, let's say, guys who had prostate cancer and had anti-androgen kind of manipulations, or breast cancer for the women, et cetera. Bottom line of it is that they got enough controls that they got this turned into a Nature paper. But subsequent, so this is the 90s, they replicated things. Their lab came up with more data on this stuff and kind of fleshed this out more, but nobody has gone back with more sophisticated modalities, especially those that we would use for living people. That might be helpful. But anyway, that's out there. All right, so if this is biology, what do we need to know? And so I'm going to switch to some, well, first of all, how I think healthcare should be delivered, and then a little bit of hormone strategy. So in terms of the healthcare delivery strategy, I threw this up there, and you're looking at that thing, and you're saying to yourself, if you pay attention to my boxes, you're like, well, wait, isn't that how we deliver healthcare in general? And the answer is yes. And so that's really the big push that I have both for us at Sinai in terms of modeling this and in terms of how things should be generally speaking, which is a patient should walk in, see the PCP. PCP has more or less experience depending upon your exposure, right? If you have some individual, this is the only trans patient, they're going to use their mental health specialist for diagnosis or their endocrine specialist for the hormone regimen a little bit more aggressively. And somebody who sees this all the time is going to go more on their own, just like anything else. And that's pretty much the whole framework. And how do we get from where we are right now to that circumstances is an interest of mine, where some of you are going to be participating with me in that primary care role. Anyway, strategy for hormones. Presentation of transgender individuals is in adulthood or late adolescence is more the norm than the exception. Still, I don't have a blood test, I don't have a scan. And so the result is I've got those individuals who are older, who've already gone through a puberty. And so that is going to influence the strategy. And is it now, maybe some younger people are coming forward, but it's still not the majority. So articulation, awareness, not known. And the other thing to pay attention to as I walk through strategy a little bit is fertility. Let's say we get to that happy place in the future where transgender people are treated how they should be, and they just come to their primary care provider and stuff happens as appropriate. There's still the case, if we don't have the technology advance anyway, that our interventions are really interfere with fertility or completely destroy fertility, and that's your tension. And I think sometimes medical people forget about that. We're so focused on whatever disease entity that we neglect this incredibly high priority for a lot of people. And so it's important just to keep coming back to that, I think. So strategy. So my cartoon says, good Lord, Ethel, you can't appear in public like that. But of course, if you don't see which way the balloon is facing, it's a little unclear which one is Ethel. And so that's kind of the good news, right? Because it just means as we age, we all kind of look alike eventually anyway. And so as long as that's fine. But in the meantime, there is the rest of life. And so along those lines, I have this. This is a photo of identical twins. And she's trans. The girl on the left is trans. They're both XY. And all you are seeing, they're just before their 15th birthday, and all that has happened so far in terms of medical intervention at this juncture is she started receiving puberty blockers, GnRH agonists, so that she would, following the typical precocious puberty regimen that we've been using for decades in endocrine and Pediatrics, so that she did not enter the male puberty. And it does point out that female, you have this female development is pretty linear, and women are just older and older versions of themselves, where and boys, people who get a lot of testosterone anyway, have this real inflection point where they all of a sudden get a lot of stuff with that testosterone. And that's actually my main point. They're just shy of their 15th birthday, maybe they're about a year into puberty here, and the boy, the non-trans one, is the point of my picture here, is look at all the stuff you get with testosterone. So he has, he's got, things that you think about, like, so midline, so like the hair up above his lip and such, but also midline structures. His nose is already getting a little bigger than hers. Just this is like 10 months of testosterone. His jaw is already squaring more. Look, move down a little bit. Look at that larynx. It's much more prominent. The soft tissues are growing down there too. His voice is obviously dropping. And you can see the SCM muscles on the side of his neck, and these are a known pair. So we know that he's a bookworm when this picture was taken and not a bodybuilder. And so that's just testosterone effect on his neck, actually. And then there's growth of the forehead as well, but bad luck in 2011. It was the style to cover your forehead with hair, and so those data are lost. But so that's part of what's going to influence us strategically. And then the other thing is to go is this recognition, and this is important to emphasize. People kind of think that testosterone and estrogens are kind of this yin-yang opposite, male hormone, female hormone, but that is just not true. Really, and if we think about it chemically even, right, we start with, let's say, testosterone that, depending upon what enzymes you have and what cells you have, conversion to estrogen or conversion to dihydrotestosterone, and actions by all of these on various receptors. And then in terms of actual hormones circulating, estradiol levels, which is the estrogen we can measure anyway, if it's relevant or not, is pretty similar in men and women. If you look at the lab, they'll say that the female levels are a little higher than the male levels, but not in a way that I would find clinically significant. And I will just say that when we look at transgender guys, if you look at their estradiol levels when they first show up and say they're trans but have never done anything medically, then the estradiol level they have from their endogenous ovarian production is just a tiny bit higher than after, let's say, I've treated them for a year or so and given them a bunch of testosterone, brought their testosterone up to male levels, kind of totally suppressing their central axis. And the estrogen that's now circulating is not from their ovaries, but rather from peripheral conversion of the testosterone that I'm giving them exogenously. And it's a little bit lower than their ovarian endogenous estrogen was, but not a lot. Statistically significant, but kind of still in the normal range. So just a modest difference there. By contrast, testosterone, probably a tenfold difference between men and women. And so that's really where the money is. And so if we kind of synthesize all of this, then we get this. First, when we're dealing with peds and adolescents, we would like to avoid permanent characteristics that we're going to have to deal with otherwise if we don't start out with some medication if we can. But again, we're a little bit, but there are some caveats which are on the slide actually. For the youngest kids, social transition is reversible, and that actually is a huge point. If gender identity is a biological phenomenon and you cannot brainwash people, then the other side of it is a little reassuring too. So for parents who are anxious about their second grader who is XY and they thought was a boy, who says, oh, I'm a girl and I want to go to school with a dress and long hair or whatever is stereotypically female so that you can show everybody who's a girl, right? Because that part's a construct. And the parent says, oh no, how can I believe my child? How does my child have any clue? And it's possible your child has no clue. It's true. And so, but if you send this kid to school in a dress with long hair, and then in fourth grade, he says, oh yeah, I guess I was wrong, I'm a boy, then whatever, just cut the hair and buy new clothes. It's reversible. So, and you can't brainwash him. I think that's my key point, or you shouldn't be able to. And on the other hand, if she was right and she is transgender, then you've done her this whole favor already by letting her express herself from second grade. So so that's just something to think about for the littlest kids, but certainly nothing medical to do. And then recognizing that even as they get toward puberty, it's not just young children present as transgender and also as adults, but even your pubescent kids think they're trans. There was a whole Atlantic cover story, very anxious about this point over the summer, where they interviewed people like 20-somethings who had medical interventions and then were not living with those medical interventions subsequently, and they had some permanent consequences. And so they were a tiny little minority of individuals, but on the other hand, we do care, right? It's not like, in medicine, we're trying to take care of everybody and cover all of those things. So that GnRH agonist puberty blocking regimen that I referenced with the twins before is kind of the strategy. We consider that reversible. It's why we use it for precocious puberty. The idea is you give it to them for the precocious puberty kids for a couple of years. Then when puberty timing would be legit, you basically just stop giving it to them. The fear there, and I'll go over that a little bit with one slide in just a tiny bit more detail, right, is that if you don't have exposure to sex steroids when you're supposed to, that you're going to have a little bit of a bone hit at some juncture in life. I will only say that for the precocious puberty kids, if you look at adults who got treated for precocious puberty with these kinds of regimens, there is not a detectable bone decrement or increased risk of osteoporosis. But for those of you who are real researchy mind or statistically mind, what that really means is that the whole number of people with precocious puberty is too small to sufficiently power a study to be able to see a small difference. So it might still be there, but the difference is at least that small, so I can say that. All right, so for adolescents, GnRH agonist, Tanner2, so for, I know this is an adult medicine crowd, but Tanner2 just means the beginning of puberty. Tanner1, it's kind of like Yelp stars. Tanner1 is nothing. And then, the bone fear, like the bone fear that you have, and so and basically these are the only trans-specific data out there, and they're not reassuring. I don't know that they're legit, but bad luck for us for the moment. It's still on our radar to think about it. Basically, what you're looking at here is a graph of Z-score bone densities. Okay, so with kids you do Z-scores because all of them have great T-scores, and so it's not helpful. And it's just comparing it to their peers. So basically, the graph all the way over at the left there is right when they get on their puberty blockers, and then you notice that they start to fall behind their puberties in the middle there, and they're not losing bone actually, they're all gaining bone, but they're just falling behind their peers. And then when you give them sex steroids later, all the way on the right, they don't necessarily catch up. And that is the whole, that's really it for this study. And so maybe that bone fear is legit. Cautions are it's a smallish study, and that it's they didn't give a lot of sex steroids, frankly, and they started kind of late. The kids were kind of pretty much into puberty by the time they got the so-called puberty blockers, and they weren't giving them sex steroids till into their low 20s or late teens. So there are a bunch of caveats, and we could maybe be more aggressive with sex steroids, and we would get different data than here. But nonetheless, those are the only data we have suggesting that could still be a concern. In the some in the United States especially interpret this as if you have a well-established trans kid, it might be a reason to get your hormones going sooner than some of the guidelines. The guidelines are very legal oriented, and they say things like start cross-sex steroids at the age of 16. But that's based on age of decision-making capacity, not on age of puberty, of course. So if you've got a well-established trans kid, maybe it's okay to say, I actually do believe this particular kid, which would be the case. And we all know there's a whole range because we have plenty of college-age people where I don't believe a thing they say, and we should be going slowly. So obviously, age is not always your indicator. All right. So for adult men, the approach is piece of cake conceptually, which is all I've got is an androgen deficit, really, from a hormone perspective, and so I just give it to them. And that's the whole treatment model for transgender guys, however you do it. We can talk about specifics, but this talk I was really focusing on the cookbook of it. So it's just, wherever you get the testosterone, it's all fine. And you just give it to the guy, basically. So, but injections or gels, all are good from my perspective, I guess is the bottom line here. By contrast, for transgender women, what we're really doing is we're blocking the testosterone. And I think that's important because even the transgender women are a little confused on the point. They think they're getting estrogen, but they already have estrogen. So that's not really what we're doing. We're blocking androgen. Now, it's true that one of the agents that we use to knock their testosterone levels down is estrogen itself. Because if you just block testosterone and you render them hypogonadal, then you guys, it's your patients, right, who you are constantly protecting them from their bones later in life, because that's like half your healthy female patients are in that situation, and so you obviously don't want to induce hypogonadism, and medically that's one of our big interventions is protecting them from this. So if we use estrogen as our main treatment model or treatment modality, then we're also protecting their bones. And frankly, the older regimens from like 20 years ago are just give these people big injections. It's still out there. Some, these 20 and 40 milligram injectable estrogen things, which are super common, especially in New York. It's very popular. Calvin Laura is very into this. And it's from an era when when estrogen was wonderful. This is back, some of us can remember, everybody came, when I was in resident clinic, every woman, that was like, if you had a heart thing, you had to be on a beta blocker, and if you were a woman, you had to have estrogen, either endogenously or exogenously. And it solved all your problems. But the problem now is that those benefits are a little bit fuzzier, except for a few things like bone health and such. And the flip side of it is we have these thrombogenesis concerns. And we don't really know what those concerns are associated with. And we got kind of three candidates and there are probably more, for what among estrogens might be bad. And so I will go over that just a little bit, because it could be a dose response thing, right? And maybe if you could give a little less, that would be better. And therefore, that's part of the reason for transgender cocktails. We actually give other agents to lower testosterone in addition, so that we can give a little less estrogen. That's the logic pattern of that anyway. Alternatively, route of administration could be relevant. The data there aren't really good either, but maybe there's a first pass effect. I'm not really, if you look at the first pass effect data, it could be a dose response effect too, by the way. But people say it's a first pass effect, and if that's relevant, that could be helpful. And then the individual kinds of estrogens could be relevant as well. I'll go through that one a little bit. Before I get to that though, just if we look at the absolute risk, I think that's important to consider too. It's a little bit like your postmenopausal women, where they have a little bit of a breast cancer risk maybe, and where you talk about, and they're like dying, from their symptoms of menopause, and you're like, well, this is the risk. If you don't have breast cancer in your family, blah blah blah. The actual risk to you, it's there. You can't lie and say it's not true, but you have to decide what's relevant in life. So here, the data. This is in the United States. There aren't a lot of American data actually. A little shy of 700 trans women over about 2 years getting estradiol pills orally, and they recorded one thrombotic event in that crowd. Those are the data. Those of you who are curious, it's that person in the yellow. But in any case, so the absolute risk is not ginormous. On the other hand, it's every time we look at it, and I'll show you some data from some slightly different angles, we seem to keep finding it. It's so this is a paper over the summer from Annals. This is the largest look yet at the subject, which is a data mining research study in the Kaiser Permanente database from a group at Emory. And essentially, they managed to pull, when they were looking, you can see what the numbers are, like 100,000 total people, and they got about 5,000 trans feminine, trans masculine treated individuals, and they were hunting for them. That was the logic pattern. And what they found when among those people with these transgender regimens, whether they were, now they're looking at the ones getting estrogens, trans feminine regimens, male to female, these degrees of increased risk, depending upon the upper group is at 2 years out, it gets even worse at 8 years out, and then the reason there are pairs of numbers is they don't really know who to compare it to. So one number is compared to non-trans men, and one is to non-trans women. In both those cases, so no matter what your control is, there's that increased risk. Absolute numbers, not ginormous. They're looking at thousands of people here. They got 150 total events across, like all of time in the Kaiser database. But it's still kind of true. And then if I'm looking at older data, and I forgot, so if I'm looking at older data, there are like 3 or so classic studies. And the biggest one that's relevant is the old study out of the Netherlands. Louis Gorin was like the daddy of the field for a couple of decades over in Amsterdam. So this is a 2008 paper, one of his last before he retired and went to Thailand. Basically, what he observed is he had historically observed maybe a 6 to 8% incidence of thrombotic events among his transgender women. But he was using ethanyl estradiol at the time, the estrogen and birth control pills, which is known to be thrombogenic, but it also helps with ovulation, which is why we still use those birth control pills. But when he switched to for them, really estradiol, with about 2,000 trans women over many years, they really did not detect an increase in thrombotic events relative to the baseline rate in the Netherlands. So again, and some of this is the numbers. If I were to flip back to the previous animal slide, where they've bumped those numbers higher, basically, in terms of overall people studied, then they could see some stuff. Maybe he just couldn't quite see it, but it's at that level. So health concerns long term. So the pitfalls that we have, like I said already, are really hypogonadism. Like when we're seeing transgender people, what is it that we're worried about? And I'm worried about like people who tell me, "Oh, I'm non-binary, just make me nothing." And there are kind of two issues there. One of them is I'm not going to make you hypogonadal because you're going to crumble. And then the other is just being honest about hormone impact. That you are going to be so sensitive that I'm just going to hang the medicine in front of you, and you're going to have these dramatic effects 3 weeks later. So, but the point that I have on this slide, of course, is that's my one harm. It's not that big a harm. Like this stuff isn't that hard actually. And then on the other side is super physiologic levels, which may expose individuals to harm without no benefit. So basically, when we're given androgens, what's the harm of androgens actually? Like all these guys taking testosterone for whatever reason, dubious reason sometimes, they have like low T, and you're like, well, I don't know, is that really low? It's kind of borderline. But the flip side of it is what is bad, and why I not personally asked Hannah about all these guys taking unnecessary testosterone. But same for my trans guys. We got some erythrocytosis. We got some stimulation of red blood cell development. And that's and your athletes know that, by the way, which is why it's not just that they're trying to build muscle; it's that they want bigger oxygen carrying capacity. But the hitch there is that is that at some juncture you let their hematocrits get high enough, there is concern that they're going to have thrombotic events from that. And we on the guidelines committee actually wrote that we want to try to keep hematocrits less than 50%. The thought process being, we've spent so many decades worrying about anemia in women, but maybe that's actually protective, right? It may really be more the larger crits in guys that are big of the problem, and that's very much an androgen dependent kind of thing. So we say 50%. Just going through that a little bit, just so you know the background of that 50%. We have no data. We stole that from the people who look at androgens in men in general, and they wrote 50% in their guideline, and they actually have no data, and they actually took that from the people in the hematology literature, where for people with polycythemia vera, the number of events starts to go up at 55%, and because they're looking at a cutoff where you would intervene, and first we do no harm, quote unquote. So therefore they set their threshold up there. We're giving exogenous androgens, and so we created a cushion. So we did a lot of hand waving. That's really I didn't even do any hand waving. It was the androgen crowd that did the hand waving. Came up with a 50% cutoff instead of 55%. Totally made up, and then we copied their made up number. All right, and then for women, thrombosis risk, like I've talked about a bunch already. So as a practical matter for these transgender guys, we're looking at the testosterone to see that we're at goal, and we're looking at their crits. And then you're looking at like cardiac risk factors and stuff like that, depending upon what's appropriate for their age and their health. No real good association necessarily with there being, well, there is some shift in lipid profile, I guess. But A1C, I don't know that there's real evidence there. In fact, I just wrote a paper suggesting that there's much less than everybody says. Yes?
So we're making decisions to add medications based on cardiovascular risk, right? Like ASCVD, we have transgender men. Do you, how much do we know about what category we should be putting them in?
Right, that's a great question. And so the short answer to that, and it's true for everything I'm going to say, is we don't know. We got and as a rough rule, you got two choices. You can either just go with their gender identity category because that's easy, and then you won't screw it up because you got this person with an M or whatever, or you go with whatever is worse. And I think the most conservative would be the latter. So in this case, you would go with a guy with a guy risk profile. So something else to think about out there, and this is like where this is the data of harms in the guidelines, in the anxiety guidelines, and up at the top is thromboembolic disease, but way down there is this anxiety for these transgender guys that androgen. Something else to be aware of. We've neglected these people for many years, and one of the results of our neglect is that they didn't have surgery. That they didn't have all the surgeries necessarily that they might have chosen. So in our guidelines, we say you should be worried about breast or uterine cancer because of androgen exposure, but we are totally making that up. In the Netherlands, which is where most of the data come from, they, by protocol, do hysterectomy or oophorectomy on every trans guy. And so they have no clue if it's true or not because they have no trans guys who actually have that exposure. But here in the United States, due to our lovely neglectful system, we have a lot of guys out there. We have not collected the data in a very, very organized way, but we are not really seeing cancers there. And in fact, when these guys sometimes do get hysterectomies, they have these very atrophic endometrium that looks more like postmenopausal, which would be reassuring.
Can I ask a question about breast cancers?
Yeah.
Female transgender patients? How do you think through mammograms?
It's the same answer that I just said, which is we got no independent data. And so I think in order to not screw up your practice, you want to just put them in the category of with everybody else, and then you'll do all your systems will work correctly, and they'll be included with the expectation that they're going to have a lower risk than the general population because they have less estrogen exposure. So if anything, you're being overly conservative by just slapping them into the category with everybody else. So this is our surgical data, my surgical data showing that these trans guys do a lot of chest surgery and not so much genital surgery, point is. And the relevance, there are a couple of elements that, but I'll come to that. But some of the relevance here is that for these trans guys, it's not just checking their levels, but this is also what are some of your screenings, and your screenings are body parts present. And most of your trans guys, importantly, are walking around with a cervix. Okay, and so somehow you got to keep an eye on that. And we have some breast, we have some self-swab manipulations right now for these guys who are really bothered by just having a conventional pap smear. But somehow you got a cervix, you got to keep an eye on it.
Is that adequate, or still need to get to do?
The way I understand the data so far, they are it is slightly inferior. But if you have a much higher rate of people following through, that compensates for its inferiority. So for the trans women, it's also checking testosterone because that's how we determine whether we got them to goal. If we're using spironolactone, which is what most of us use as the adjunct anti-androgen, then it's potassium-sparing diuretic. You check K. I don't think that should be pretty straightforward. I'm going to just point to one thing that has been on the list for ages, which is prolactin, because that's an estrogen-sensitive tissue, and it just shows you how much research is needed. Before I get to that, I guess one other aside for organs here. Your transgender women who have had vaginoplasties, the surgery is basically taking the penis and making it inside out, in brief. And the bottom line, though, is they don't go back there scooping out the prostate and risking harm to the urethra. And so it's still there. And I think that's like the key element there from an exam perspective. Anyway, what I was about to say there is this prolactin thing. It's sitting up there in our guidelines even. And this is just some evidence of why we need to bother to look at these things a little bit more carefully. The European data have a little bit of a prolactin bump in them, but when I looked at Boston, these are my prolactin levels among my patients over 6 years. And you can see, none of us are really seeing this. I have the odd person with a high prolactin, not trans women, and then I investigate it like I would any other individual with a high prolactin, like from a pituitary perspective, but I have nobody where I could attribute the high prolactin to their trans estrogen regimen. And so maybe that has to come out of guidelines, actually. Okay, surgical options, I want to say like 2 points to them. And it's really this. So first, for the trans guys, and I think this is just important to in terms of thinking, that they're doing tons of chest reconstruction. The genital surgeries, like I alluded to way back at the beginning, don't work so well, which is why the logic pattern for ambiguous genitalia was what it was. But that means that currently, I still find those genital surgeries suboptimal, and those trans guys mostly are not choosing them. We do them at Sinai for those guys who want them, and the guys who do want them want them. And they're very happy, and they challenge me, and they say, no, you don't know what it's like, blah, 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 blah. And so I'm sympathetic. I don't want to be patronizing here. But the flip side is they don't have erectile function. They don't have good sexual sensation. I give them a boatload of androgen. Their female genitals get very, very, they have great sexual function, actually. And so I'm more sympathetic, I think, to the majority personally, who are saying, don't cut into my genitals, that are working just fine until you've got something to offer me. But the minority who do want the appearance to shift exist, and we can take care of them, but they are the minority. That's a lot of my point. I had to make that point too. Yeah.
Sorry, does Medicaid pay for those?
Yes, Medicaid in New York is pretty helpful. We have, so specifically your managed Medicaids are usually pretty good, not 100%. Like a Medicare, they are lovely. We have a very tight relationship with them. What's the one I've just got here? So I have Fidelis. They're terrible. Do not, yes, they should switch. That's bad. Okay. And then for your transgender women, I think the key point here is that people are, again, very genital focused, like for the guys. Unlike the guys, the vaginoplasties work a little better, at least from a sexual function. The nerves, we try to maintain the nerves and blood vessels. Women are orgasmic mostly, actually, postoperatively. But the big point is, and this relates to the fact that a lot of them have gone through male puberty and things like that beforehand, that other surgeries could be higher priority. Facial feminization surgeries, chest surgeries, and frankly, depending upon who they've developed relationships over the course of their lives, the genital surgery may or may not be important. And so I just want to back off from this genital focused thing. We have some states and some countries, Western countries, where they actually won't change your gender marker until you had a genital surgery. And it's like, that's wacko, especially for the guys who almost never do it. And even for the women, where it's it's more evenly divided than I think people recognize. And I think I timed it, post-surgery, less estrogen, just some things to think about going forward. Access to surgery is increased. We've got access to surgery here at Sinai, and we will increase our access. Part of our mission is to mainstream this. And what does that mean? The fact that there's a 3-year waiting list at NYU, they're not our benchmark, okay? And we've got a 2-year waiting list. That's not, so we're better? Nah. The issue is, let's say for other elective surgeries, you maybe need to wait 6 months for surgery, and we need to get ourselves to that point, and we need to we need to train fellows and get other places to that point too. So that's more our mindset. But the flip side is, and my younger trans kids point out that some of them don't do surgery at hormones as much. They're like, well, I'm trans, they change their clothes, and if society will put up with their appearance and be more respectful of them, they're a little less intense sometimes in some of these interventions. I don't know which way this is all going. All right, so there we go. I think even with the 5-minute late start, we're good. So thank you very much for your attention, and I'm not running anymore. Good.
Someone who's high risk for hormonal disease or
Yeah, that's an enormous question. We didn't go to the hard questions, which are, you've got somebody with venous thrombosis. So now let's. Yeah, so the question is, what's the estrogen risk versus what's the rest of their risk, right? So we're all so busy saying, oh, let's take away that estrogen. But are you really protecting them that much, taking away their estrogen? That's a question. And I don't have good data for this, but it is a question, especially when I'm looking at absolute numbers. And so is that a false security and I'm torturing them for no benefit? And so that's just something to consider. So I would not, for example, for a woman with ovaries, remove her ovaries or block them medically and say, oh yeah, that's my solution to your thrombotic concern. I would anticoagulate or whatever I need to do, depending upon their circumstance. And so perhaps for a trans woman, that ought to be our priority too, not stopping her hormones, but otherwise addressing it, putting her on her aspirin or something else. And even perioperatively, we don't as much at Sinai, but many places still hold estrogens. Perioperatively, we do a little bit. We have like a conflict. One of the surgeons says don't stop the estrogens, and the pre-op testing lab group says do. So, but the bottom line of it is is that we don't is that we're basically holding estrogens for a week or two. But like if you've got somebody who's getting a hip issue, you don't consider that. Oh well, you're postmenopausal, so you'll be fine. We don't say that, right? Because that's not even true. The issue, that immobility thing far outweighs, and some antithrombotic regimen, DVT prophylaxis regimen is what you really need. So anyway, that's my answer. We've kind of got to rethink that one a little bit and focus there. And that's what I would do. And I have trans women, older trans women on their estrogens, and they're saying, "Don't stop my estrogens. Can't I just take an aspirin?" And I'm like, we should do some studies. But I bet you're right, because that's probably going to have more bang for its buck actually than stopping your estrogens. Good. All right.